I'm going to turn it back to Dr. Shapiro, and then I'll talk to you a little bit more about what to do when we think children are being abused.
Thank you. I'm going to briefly talk about another area of research that really impacts practice, which is the whole idea of the assessment of the potential for future violence. So often we get the question, clinically and particularly in forensic settings, doctor, is this person dangerous? And basically, dangerousness is no longer a meaningful term to us. What we're talking about is not dangerousness, because it is so vague, but really a risk assessment for the potential for future violent behavior. The research has demonstrated well over 30 risk factors that go into violent behavior. These risk factors have been detailed in what are called the MacArthur research studies. Far too detailed to describe here, but suffice it to say it is a very comprehensive, complex assessment that really has to go into many, many different areas that are related to potential violence. Again, it used to be thought that a person would sit down with a doctor, psychiatrist, psychologist, and through some sort of magical interview, they would be able to figure out in the course of an hour or two whether or not this person was potentially violent. Well, it turns out that the research there that was done on those kinds of studies showed that we were most often wrong. In fact, we were wrong 2 out of 3 times. We tended to greatly overpredict the potential for violent behavior. You may say, why is that so important? Well, it may lead to unnecessary involuntary commitments of people. It may lead to their being not able to be released from confinement, and in some extreme cases, it may lead to their execution. All of these are different uses of the belief that a person is going to be dangerous or going to be violent. So for about the past 20 years, researchers have been studying the factors that do go into assessment of violent behavior. And essentially, it's come down to both clinical and actuarial assessment. They're sort of combined nowadays in what is called structured professional judgment. What we do is to take the areas that the research has identified as areas relevant to the risk for violent behavior and interview in depth the individual and do various assessment instruments in each of those areas. The MacArthur research said that 5 areas were important: psychological factors, sociological factors, biological factors, contextual factors, and demographic factors. That each one of those needs to be studied in its own right and integrated into a comprehensive assessment. Unfortunately, a lot of people, and here we get to the systems approach once again, take one or the other approach, fail to integrate it, and come out with only a partial kind of assessment. What one is ultimately doing is making a probability statement based on the context. We are saying that given this number of risk factors, they are at minimum risk, moderate risk, high risk of acting out within the following contexts. And that, of course, also gives us some way of intervening in these different situations. If the acting out behavior is in one particular context, then our intervention or treatment or management efforts can focus on that one particular area. Okay, let me turn it back to Dr. Walker now, who's going to talk about mandatory reporting in child abuse, elderly populations, and disabled populations.
Thank you, Dr. Shapiro. Here's an area that really has some great difficulty for those of us who are mental health professionals, because it takes a lot of our ability to make reasonable decisions away from us. If we have the belief, the opinion that some child is in danger, we have no choice but to report it to the child abuse authorities in our states. Every state has laws about reporting child abuse and mandatory reporters, and all mental health providers, at least to the best of my knowledge, all mental health providers are in the mandatory report category. Different states have different ways of following through. Some actually say that you're only getting in trouble if you don't report if it's a willful non-report of child abuse. Others say you better report even old child abuse situations. And sometimes that can cause major system errors. For example, there could be reporting of something that happened 30 years ago, and the person who was the perpetrator may be demented at this point and in the psychiatric hospital or in a nursing home. What good is reporting at that point? Sometimes reporting destroys the family totally. Again, that's not our choice. We have no choice. We must make the report and hopefully work with the family so it's not as destructive. Now, in some states, there's also elder report laws. For example, the state of Florida, we have to report any kind of elder abuse if somebody is over the age, and elderly is over the age of 55 in the law, which I know Dr. Shapiro and I are not too pleased at being in that designation, but we are. So don't abuse us. So we do have these kinds of responsibilities to really be protective of our clients and protective of citizens, and at the same time try not to allow the system to intervene in such a way that it's destructive rather than constructive and supportive for the children and the family. The clinical judgment then in most of the states is not a defense against non-report. In other words, you can't say, well, yes, the child reported abuse, but the parent said the child was really just manipulating, and it was my clinical judgment that the child really was manipulating. Well, that might be true, and you might be the best trained person to make that kind of decision. We don't have the ability to do that. The professional has no choice. We must make the report. And so, as you can see, sometimes making that report can be more difficult because sometimes you make the report and you lose the client. The client drops out of treatment. And again, it's the best thing we can do to prevent that is to try not to make a report when the client doesn't know what's happening, to try to do it together with the client and try to be able to explain to the client why it is supposed to be protective of the child and of the adults. Some states also require you to report an adult who's being abused. Very few states, because that really is something that takes away the power of the adult who is not considered a vulnerable person to make that report, unless the adult is a vulnerable person, a high-risk person. And again, the state law describes who that would be. So it's important for you to know what's in your state law in order to know what your responsibility is. So I'm going to turn it back to Dr. Shapiro, who is going to spend a little bit of time talking about how you can help do these kinds of system errors by keeping good records and at the same time protecting yourself, because the best defense you have to anybody's complaints against you is your note-taking and your record-keeping.
That's very accurate, Dr. Walker, and especially considering the fact that most mental health professionals are notoriously poor at keeping records. It is something we do not like to do, we find it tedious, and we don't really see the bigger picture of why it's important to do it. First of all, note that many of these medical errors occur because of poor record keeping. But we do now have guidelines, both from the different states, and from APA that recently revised their record-keeping guidelines. In 2007, APA revised the guidelines from 1993, and they provide guidelines that can assist in avoiding making the kinds of medical errors that we've talked about thus far. Why should we keep records? Well, obviously to document services rendered, document our assessment and treatment plan, and needed for communication if we need to provide information to third parties. The therapist herself or himself can actually review the progress notes to see what the progress or lack of progress has been, to help them decide on whether there should be a different course of treatment. As Dr. Walker mentioned, it is the best single defense against malpractice complaints and licensing board complaints. When there is a complaint about your therapy or diagnosis, a board will always be asking you for a copy of your records. The records are, and some people have written about this, the best single defense in an age of litigation. They document what you have done, what your thinking has been, whether or not you have adhered to a standard of care. I've actually heard a number of psychologists say, I don't need to keep records, I'm a superb clinician, quote unquote. That actually came from a complaint that I reviewed. Well, no matter how good a clinician you are on indefensible territory if you do not keep careful records. Ethical Standard 6.01 of the APA Code says that psychologists have an ethical and professional responsibility to develop and maintain records. The records also have to show that you comply with the legal standards regarding confidentiality, that there are only certain circumstances, certain very limited circumstances under which confidentiality can be broken. We have a new, well, not so new now, it's been around almost 20 years now, called HIPAA. I used to call it new. It's no longer new.
20 years, it's hard to believe.
Health insurance portability and accountability. HIPAA is protective of the client, of the patient, and basically has a whole series of very, very complex regulations, which can't begin to describe here, except that HIPAA, from this point of view, HIPAA requires that we keep records.